Hi, class. This is Dr. Weaver, and today I'm going to record a lecture on sickle cell anemia. This is Adult Health 2, Chapter 40, and we are dealing with care of patients with hematological problems. So just take a listen. Hopefully we can hit some very important points here that will help you to be successful on your next exam. All right, so again, we'll be talking about sickle cell anemia, a very common condition that you will see in the hospital. So it would be important for you to really listen very carefully because these patients are pretty complicated. They have some pretty complex cases when they are admitted, so pay attention. These are some objectives here that I would like you to be able to perform after this lecture is completed. And I won't go through them. You can read those at your own leisure. And these are some priority concepts for this chapter: perfusion, immunity, and of course perfusion concept is an exemplar for sickle cell disease, and you'll learn about that as we go through the presentation. And also immunity is an exemplar, is the exemplar of leukemia, although I've already discussed leukemia, so we won't be going over that. There's already a voiceover for that as well. And some interrelated concepts for this chapter is cellular regulation, gas exchange, and also clotting. These are all concepts you need to really focus on in order to help you to get a better grasp of the information. So as far as sickle cell disease is concerned, it is a genetic hemoglobin disorder, as I'm sure many of you do know. And essentially, it is the formation of abnormal hemoglobin chains. These patients do have periodic episodes of cellular sickling, or crisis is what we refer to it as. And it is this crisis that actually brings these patients into the hospital. This condition affects mostly, or is most commonly found in African Americans in the United States. But of course, when we say most common in African Americans, but that means that other folks of other races can be impacted by this condition as well. So keep that in mind. So sickle cell disease is a genetic hemoglobin disorder that results in chronic anemia, pain, disability, organ damage, and there's also increased risk of infection. Remember, immunity being the interrelated concept, and early death due to poor perfusion of blood, especially to a variety of organs. It is the worst of its kind compared to other hemoglobin disorders. Remember, perfusion is adequate arterial blood flow to the tissues, and this is referred to as peripheral perfusion. And of course, we have blood that is pumped by the heart, and that would be considered a central perfusion to oxygenate body tissues. Now, a healthy adult has normal hemoglobin, or we refer to it as hemoglobin A with a capital letter. And it is greater than 98% hemoglobin A is in the normal adult. All right. NSCD, sickle cell disease, About 40% or more of total hemoglobin is composed of abnormal beta chains, or AKA hemoglobin S as in Sam. Now, formation of abnormal hemoglobin chains. In sickle cell disease, the hemoglobin S is sensitive to low oxygen content, and this leads to abnormal beta chains. They actually contract. They also pile together within the cell, and of course, this leads to a distorting cell. This actually distorts the cell into a sickle shape. And what this actually leads to is sickle cells become very rigid and they clump together. Now, the red blood cells become sticky and they also become very fragile. Because of this, it will lead to clumped masses of sickle cell red blood cells that actually block the blood flow or perfusion. So, red blood cells are they're not supposed to stick together. They're supposed to move freely throughout the vascular system. But in this case, because they're sticky and they clump together, they can actually clump together so much until they actually cause an occlusion, if you will, particularly occlusions to different organs. Let's say even the renal system in particular, or any system, it can block or cut off circulation, but that clumping can just basically cut off blood flow. Again, we're back at perfusion, which is one of the priority concepts. When blood flow is blocked or perfusion is altered, we refer to this as vaso-occlusive event, VOE. V is in Victor. Now, VOE leads to tissue hypoxia, and this is because there's a decrease in oxygen supply. This leads to more sickle-shaped cells, and this will eventually lead to destruction of blood vessels. Perfusion then becomes inadequate, and ischemia affected tissue. The tissues are not getting enough blood, so you have an ischemic episode here with the sickle cell condition. Now, there are some conditions that cause sickling. That is, when these patients are hypoxic, if they are dehydrated, infection. There's also venous stasis, meaning blood moves very slowly, stagnated. Pregnancy also leads to a crisis. Alcohol abuse, high altitudes. Just think about people going to a game in Denver, the Mile High Stadium, or of course we know Denver is so many, I believe, thousands of feet below sea level. There's also low and high environmental or body temperatures. Acidosis also leads to a crisis. If these patients participate in strenuous exercise, emotional stress, to name a few. So there's more. If the underlying cause is corrected, such as if the patient is dehydrated and you rehydrate the patient, the sickle cells go back to the normal shape of the cell, especially when oxygen content normalizes. And of course, this will lead to normal tissue perfusion. Some of the cells still remain twisted while decreasing its flexibility. One of the characteristics of red blood cells is its flexibility, ability to move freely throughout the vascular system, which it has to in order to supply oxygen content to the various organs. Now, over time, the cell membranes of these red blood cells are damaged and they become permanently sickled. These cells, the hemoglobin S cells, are more fragile and they are easily broken cells. Now, the normal red blood cell lifespan is about 120 days, compared to 10 to 20 days of the hemoglobin S cells. So it is this reduced lifespan of red blood cells that causes what we call a hemolytic anemia in sickle cell disease patients. When we say hemolytic, the blood cells are being destroyed. So SCD patients have periodic episodes of extensive cellular sickling, and this is referred to as a crisis. The onset are sudden and can occur weekly or maybe once per year. Many times, these sickle cell patients are in good health until a condition that results in local or systemic hypoxemia. And so when that happens, of course, you have a decrease or deficient oxygen in the blood, that is hypoxemia. This will occur. Also, patients with repeated VOE, the vaso-occlusive condition, and impaired perfusion in the large vessels, this will actually lead to long-term damage to tissues and organs over a period of time. Most causes of damage come from tissue hypoxia, anoxia, meaning without oxygen, ischemia, meaning less blood flow, meaning also less oxygen, and eventually cell death. Now, sickle cell patients' organs, such as the spleen, the liver, the heart, the kidney, the brain, joints, and the retina, they do develop over time small infarcted. When we say infarct, there's a death to these different areas in these organs, kind of like a heart attack. You have a myocardial infarction. It is death of a tissue. And so you have these small infarcted areas or scar tissue formation in these organs. And of course, eventually, when enough scarring occurs with these organs, it leads to organ failure. As far as etiology and risk, genetic risk, SCD is a genetic disorder with the autosomal recessive pattern inheritance. You better know that. In SCD patients, they have two hemoglobin S gene alleles. This is all we're getting into the genes, which it is inherited rather from each parent. Patients have about 80 to 90% hemoglobin S. Remember, the S is the sickled red blood cells in sickle cell patients. If SCD patients have children, each child inherits one of two abnormal gene alleles and sickle cell trait. As far as the sickle cell trait is concerned, occurs one normal gene allele and one abnormal gene allele for hemoglobin inherited. And only half of the hemoglobin chains abnormal. In other words, these patients, if they have children, can pass on the disease as a trait to their children. As far as incidence and prevalence, SCD can occur in people of all races and ethnicities, but mostly in African Americans, as I mentioned earlier. Many people do carry the trait, about or approximately 8% of the population. Now, as far as assessment is concerned in our SCD patients, which is a chronic disorder, by the way, pain is the most common sickle cell disease symptom, but there's also a variety of system changes: cardiovascular, respiratory, skin, abdomen, kidney and urinary, musculoskeletal, and central nervous system. When these patients are actually, or excuse me, are acutely ill in crisis, they're usually treated on a medical surgical floor. Those with the trait aren't usually ill, but they do have hemoglobin S cells, so keep that in mind as well. These are just the ones who have the trait. So what the nurse you as the nurse should be asking these patients, as far as when you're taking their history, when they're initially admitted and what have you, is you want to talk about previous crisis that they've been in, a sickle cell crisis, what led up to it, how severe it was, and the usual management. So you ask about contacts. You want to ask them about contacts with patients who are or people who are ill, and also activities that can cause current crisis, and ask about also signs and symptoms of infection. We want to also review all activities and events within the last 24 hours, such as food and fluid intake, if they have been exposed to temperature extremes, whether that be very cold, very hot, what kind of drugs they're taking, exercise, trauma, stress. Have they had recent airplane travels? Remember that high altitude. Also ask about their drinking history, illicit drugs, alcohol abuse. That's what the ETOH means, alcohol abuse intake. We also want to determine their energy level as well. Signs and symptoms of SCD, well, it depends on the site where there is reduced perfusion and tissue damage. So if you get reduced perfusion to the heart, then you have chest pain. You have a reduced perfusion to the kidney, you have flank pain, and so forth. Now, pain is the most common SCD symptom, as I mentioned. Also, as with respect to cardiovascular changes, these patients have signs and symptoms of high output heart failure. Remember, we learned that in the cardiac chapter. And this is due to anemia. It is the anemia that is causing, because the body is detecting that it's not getting enough oxygen, so it will cause the cardiac output to increase in order to correct that, but it won't correct it because these patients are anemic. And until you correct that, then it's just a vicious cycle. These patients are also short of breath. They have generalized fatigue and weakness. And there's some additional information that I want you to read in that section. There's also respiratory changes. These patients typically have pulmonary hypertension. They are at risk for pneumonia. So these patients will need a pulmonary function test to assess the severity of this disease on their pulmonary system. Now, these patients also have acute chest syndrome that is common. That is a common cause of a hospitalization. Again, acute chest syndrome. This is a common cause of hospitalization. It is also a common cause of death, which occurs from respiratory infections and fat embolism, and also pulmonary debris that comes from the sickle cell. As far as signs and symptoms are concerned, these patients, they have a cough, they're short of breath, they have abnormal breath sounds. If you do a chest x-ray, you will note that they have infiltrate in the lungs, which can indicate pneumonia. Possible fever. Again, we're back to the immunity. This may lead to a respiratory failure and failure of other organs. Remember, you're not getting this perfusion to other organs. So just go back to cardiac, and remember with our CHF, when the cardiac output is altered, these patients are not getting enough blood to their organs. Well, sickle cell is the same thing in the sense that if you're getting all this clumping and the sticking together of these red blood cells, and they're blocking our vascular system that delivers oxygen, nutrients, and what have you to the various organs, then they'll begin to fail likewise. Another condition these patients experience is priapism. This is prolonged penile erection. The cause is excessive vascular engorgement in the erectile tissue, so there's a lot of blood being shunted to the penile tissue. This is very painful. It lasts for hours, and these patients cannot urinate during these events. So this is very dangerous. As far as skin changes, these patients experience pallor, cyanosis due to poor gas exchange from decreased perfusion, as well as anemia. You want to look at these patients, their lips, tongue, nail beds, the palms of their hands, at least every 8 hours for color change. If the patient has a cyanosis, the lips and the tongue are gray. The palms, the soles, and the conjunctiva and nail beds become a bluish tinge. The skin is also jaundice due to red blood cell destruction and the release of bilirubin. And for dark-skinned people, and pay attention to this, when you want to check to see if they have jaundice, you want to look at the roof of the mouth for that yellow appearance. And also check the sclera on these patients closest to the cornea to assess for jaundice as well in blacks. Jaundice can cause intense itching of the skin. So that may be something you may have to provide some comfort to your patients, bathing and maybe Benadryl and those kinds of things. We want to also check for ulcers to the lower extremity. Why? Decreased perfusion to the lower extremity can cause ulcers. And again, this is, well, I said that, decreased perfusion. And this is located, generally located to the outer sides and inner aspect of the ankle, the shin, which can become necrotic due to poor perfusion, or infected. And we'll need debridement as well as antibiotics. That ABX is antibiotics. Abdominal changes. The spleen, the liver is damaged and occurs early due to hypoxia and ischemia. During crisis, the abdomen pain is from reduced perfusion. Again, this is a perfusion issue. Remember that priority concept. Keep that in mind. It's all about perfusion. And of course, this can also involve the back, the legs. The liver and the spleen can feel firm and enlarged with nodular or lumpy texture, when you're palpating this area or, the area of the liver and the spleen. It has that nodular or lumpy feel to it. And this actually occurs in the late stage with these patients. Kidney and urinary changes. There's damage from poor perfusion and decreased tissue gas exchange. These patients can develop CKD from anoxia meaning without oxygen, damage to the kidney nephrons. And of course, when that occurs, there will be less filtration and reabsorption by the kidneys. Remember, that is their function. As far as musculoskeletal changes, changes occur due to arm and legs of the usual sites of blood vessel occlusion. Again, the arms and the legs are usual sites of blood vessel occlusion. So you may see these patients lying in bed, grabbing onto their arm and complaining of pain, or they're kind of thrashing about in the bed, just rocking back and forth in pain. Joint damage from hypoxic episodes come from hypoxic episodes, and they have necrotic degeneration. Again, necrosis comes as a result of poor blood perfusion. Remember, no oxygen, no nutrients, or what have you. We want to check for a range of motion in these patients, as well as pain. We want to check their arms and legs for color, for swelling and temperature differences. You may have more occlusion in one arm versus the other, so you want to compare those differences. And as far as the central nervous system changes, the patient might have low-grade fever. The long-term effects of reduced perfusion to the CNS results, again, in infarcts, infarction, due to repeated episodes of, again, hypoxia, which can lead to seizures or symptoms of CVA. These patients also may have cognitive or behavioral changes, which are early indications of cerebral hypoxia. So that was quite a bit for that section. And moving on. So as far as priority collaborative problems for patients with sickle cell disease, and these are some good nursing diagnoses that you can use. Pain related to poor tissue oxygenation and joint destruction, and potential for infection, sepsis, multi-organ dysfunction, as well as death. As far as lab assessment, diagnosis is based on the percentage of hemoglobin S on electrophoresis. Also, the number of red blood cells with permanent sickling is another indicator. So the value is found in up to 90% of patients with SCD. The hematocrit is also low with these patients with SCD. The reticulocyte count is high, which indicates anemia of long duration. So this has occurred over a long period of time. High total bilirubin is due to damaged red blood cells, released iron, as well as bilirubin. White blood cells can be high, which is related to inflammation and also due to tissue hypoxia or ischemia. Imaging shows bone changes due to chronically stimulated marrow and low bone oxygen levels. Some tests, such as echocardiogram, ECG, X-rays, ultrasounds, MRIs, PET scans. I have PET show, but PET scans will show soft tissue and organ changes, again, from poor perfusion and chronic inflammation. So these tests can be useful. I don't know why I have this on this particular slide, but I may not have to discuss it. May not have to discuss it on the next slide. So we'll see. I'm actually doing this in the classroom, and typically I'm at home, and I have my dual monitor where I can see what I'm going to be discussing next. But this information may have come a little early in this particular format, if you will, and maybe not. So as far as how we manage these patients, we're managing their pain by way of drug therapy, by hydration. We also want to prevent sepsis. So this involves continual assessment, also prevention and early detection strategies. Drug therapy is also involved in prevention of sepsis as well. And we also want to get into care coordination and transition management. Now, as far as managing pain, pain in SCD crisis is due to injury, due to poor perfusion, and poor tissue gas exchange from obstructed blood flow. Again, that clumping, that stickiness together, occludes blood vessels, and blood vessels, remember, deliver oxygen, nutrients, and so forth to vital organs. And so this is what's happening in this condition. Pain is associated with sickle cell disease when they're in the acute phase. And also there's these patients have pain from chronic complications. So they, because this is a long-term chronic condition, pain is associated with the chronic cases as well as the acute. Pain involves usually the chest, the back, abdomen, and extremities. Complications of SCD can cause severe chronic pain and patients needing large doses of opioid analgesics. So these patients will require quite a bit of pain medications, especially in the acute period. So we want to assess their pain by using a pain scale. This is something you all really need to hear, and that is do not worry about addiction, as few of these SCD patients become addicted. So don't be so quick to accuse patients of drug seeking. This attitude tends to provide inadequate pain relief. So when they ask for pain medication, you give it to them. All right. Pain management is based on past pain history, previous drug use, disease complications, and also current pain assessment. Addicted patients in crisis must still have pain relief as well, so don't forget that. I want you to also look at chart 40-1, page 811 on care of patients in sickle cell crisis. Really important information for you to know. Now, the first 48 hours when these patients come into the hospital, they are given IV narcotics with morphine or Dilaudid, and they're given it on a routine schedule. In other words, it's not given PRN or as needed, but a routine. So it might be every 4 hours, every 3 hours, or what have you. They also may have a PCA Dilaudid or morphine pump where they can self-administer over certain intervals of time. After these patients receive a certain measure of relief, then we can switch them to oral pain medications because when we discharge them home, they are not discharged home on parenteral narcotics. No PRN medications, as I mentioned, only routine. These patients can receive NSAIDs, which I don't recommend particularly, or PO opioids. There's a medication called hydroxyurea, I believe, and this medication actually reduces the sickling and pain episodes by stimulating fetal hemoglobin F as in Frank production. The drug, it does increase risk for leukemia, and it does suppress bone marrow function. So those are some of the downfalls of this medication. It is also teratogenic, meaning cause of birth defects in fetus. And so the CBC should be assessed for drug toxicity. If you want to know if this patient is toxic from this drug, a CBC would be your test of choice. As far as hydration, oral and IV hydration helps to reduce the duration of pain episodes because you're basically, you have much more fluids where your blood vessels can move more freely, and you're kind of trying to minimize some of this clumping that is taking place with these sickle cells. So we want to provide a hypotonic fluids at about 250 mLs or cc's per hour for about 4 hours. Once the blood osmolarity is between 270 and 300, and you can look at that on a laboratory test called a BMP, B as in ball, M as in Mary, P as in Paul. You can look on that particular test and it will tell you what the serum osmolarity is. Osmolarity just speaks to how either concentrated or dilute the blood is. At some point after the 4 hours, we want to decrease IV rate to about 125 cc's per hour. As far as preventing of sepsis, SCD patients, they're at greatest risk for bacterial infections due to reduced immunity from anoxic damage to the spleen. Remember, the spleen is part of the immune system. And also remember, immunity was a part of the interrelated terms that we discussed earlier in the slide presentation. So immunity is a factor here, and it is reduced because the spleen, again, is an immune organ, part of the immunological system. If sepsis is suspected due to perhaps a fever, we do want to obtain a CBC with the differential, blood cultures, reticulocyte counts, urine cultures, and also a chest X-ray. And we want to also start prophylactic antibiotics straight away in order to reduce complications of sepsis. The most effective way to prevent infection is hand washing. Staff should wear a mask if they have an infection in order to not make the patient sick, since they're already compromised. Strict aseptic technique for all invasive procedures. There should be continual assessments. We want to observe for infection. We're looking at our CBC, especially the WBCs. Also inspect the mouth for lesions indicating fungal or viral infections every 8 hours. We're assessing the lung sounds for adventitious breath sounds. We also want to inspect the urine for infection. Remember cloudiness. The urine should not be cloudy. Also, we want to assess the vital signs every 4 hours. As far as drug treatment is concerned, these patients are started on penicillin to reduce pneumonia or streptococcus, infection. These patients should also receive pneumonia vaccinations and also annual flu shot and a treatment of actual infections with the proper antibiotics based on the sensitivity report. Just like I showed you in class, you have the R's and also the S's, and you want to choose the S's because that's what the organisms are more sensitive to. Management should also be focused on prevention of the vaso-occlusive condition that these patients experience because we want to promote perfusion. And this will lead to lower acute chest syndrome when we can accomplish this. Some interventions, we want to remove restrictive clothing. Don't want to cut off circulation because they're already having perfusion issues. We want to administer oxygen to minimize sickling. Remember, with hypoxia, there's more or increased sickling. We want to also monitor oxygen saturation and ABGs. These patients may require a transfusion of RBCs to increase the hemoglobin A levels and also to dilute the hemoglobin S levels. Now, caution on SCD patients who receive blood transfusions because these patients become prone to iron overload from repeated blood transfusions. So remember that. Signs and symptoms of iron poisoning may include burns or redness around the mouth and lips, the breath that smells like chemicals such as gasoline or paint thinner, also vomiting, difficulty breathing, drowsiness, confusion, or other altered mental status. Hematopoietic stem cells is an option for these patients. There's been some success from what I understand, but the experience can be life-threatening for these patients. As far as care coordination and transition management, these patients and families must be taught how to prevent crisis and complications, such as rehydrating, avoiding extreme temperatures and whatnot, limiting stress, etc. Want to teach patients to avoid activities that can lead to reduced gas exchange from hypoxia and hypoxemia. Teach them how to recognize early signs and symptoms of crisis so that they can intervene early, may be able to prevent a crisis, hence avoiding an acute hospital admission. Must teach them how to prevent infection, pain, and other complications, and also permanent tissue damage. We also want to teach these patients to use appropriate opioid analgesics at home. Also, we want to refer these patients, particularly if they want to get married, have children, we want to refer them to genetic counselors for possible birth control or pregnancy options. We also can refer these patients to local sickle cell foundation chapters as a resource. I'm not sure if that is actually it. That is actually it. As a matter of fact, I'm going to keep on going with this one. This particular one, we're dealing with anemia. Anemia is a reduction in either the number of red blood cells, amount of hemoglobin, or hematocrit. It is just a clinical indicator. It's not a specific disease. For example, with sickle cell disease, a patient can become anemic. Anemia is not the disease itself. Anemia just came about because of the disease sickle cell. But they are manifestations. Anemia is a manifestation of several abnormal conditions. I want you to look at table 40-1, page 814 for various types of anemia, and see chart 40-3, page 814 for how various body systems are affected with anemia. For example, as far as cardiovascular, these patients may develop murmurs, gallops, tachycardia, at basal activity levels. In other words, they're not really doing a whole lot, and they can still develop these tachycardia. Increasing with activity, and also during and immediately after meals as well. As far as respiratory, it can cause dyspnea on exertion and also decrease oxygen saturation. Neuro is impacted. It causes increased somnolence, fatigue, a headache, and just look at the other information in this particular section. Now, common causes of anemia, sickle cell disease, this glucose 6-phosphate dehydrogenase deficiency anemia, immunohemolytic anemia, iron deficiency anemia, vitamin B12 deficiency anemia, folic acid deficiency anemia, and also aplastic anemia. So there's a variety of different types. As I discussed earlier, sickle cell disease is an autosomal recessive inheritance disorder. This G6PD, this deficiency anemia, it is an X-linked recessive deficiency. This is seen more in men, by the way. It affects about 10% of Blacks, but more common in Middle Eastern and those of Asian descent. The G6PD, it stimulates reactions in glucose metabolism, which is important for energy in the red blood cells, as red blood cells, they have no other way to produce ATP. And this is something, ATP, remember that from microbiology, that energy. And so the cells need glucose for metabolism. So cells lacking G6PD leads to the fact that they can easily break when exposed to certain drugs such as aspirin, high doses of vitamin C, benzene, etc. There's some additional information there. Patients usually don't have signs and symptoms until they are exposed to triggering agents, or until severe infection develops. After exposure, acute red blood cell destruction or breakage begins, and it lasts for about 7 to 12 days, and this will lead to anemia and jaundice as well. Remember, when the red blood cells are destroyed, that bilirubin is also released, causing jaundice to the skin. Treatment of G6PD, prevention is the most important treatment. Men who are high risk should be tested for issues, drugs that are given that cause hemolytic reactions, like the aspirin that we just mentioned. Hydration is key for episodes of hemolysis to prevent the debris from the hemolysis and hemoglobin from collecting in the kidneys, kidney tubules, which can actually cause or result in acute kidney injury. So, when those red blood cells break, debris is developed as a result. And it is those little debris and the hemoglobin itself, these particles, they can lodge into the kidneys and cause a decreased kidney function. Mannitol, which is an osmotic diuretic, is used to prevent this particular complication. So remember mannitol. Look up your mechanism of action for that drug. We can also transfuse these patients if anemic, but they have to have normal kidney functions in order to do that. Now, we also have the immunohemolytic anemia, or AKA autoimmune hemolytic anemia. Abnormal immune function, in which this is an abnormal immune function rather, in which a person's immune reactive cells fail to recognize his or her own red blood cells as a self cell. So in other words, it looks or it appears to be a foreign body. This results in destruction of the cell membrane, which also leads to accelerated red blood cell production. Now, the immune system products such as antibodies will attack the patient's own red blood cells, and so they really don't know why this occurs. As far as treatment is concerned, steroid therapy helps to suppress immunity, and this is temporarily effective. If ineffective, these patients would have to have surgery. They would have to have a splenectomy as a result. Now, more intense immunotherapy with chemo drugs may also be required. These patients also may benefit from plasma exchange with the intent to remove antibodies from the system if they're not responding to the chemotherapy or drugs. So with plasma exchange, the goal is to remove those antibodies that are causing such destruction. There's also iron deficiency anemia, or IDA. This is where you have a decreased iron supply. Inadequate iron intake might be due to diet. It may also be due to chronic alcoholism, and there's also some additional information there. From also rapid metabolic activity like pregnancy or such that occurs in pregnancy and infection, etc. The most common anemia, this is the most common anemia worldwide in populations such as women, older adults, and people with poor diets. Patients should be assessed for GI bleed. Let's see. Patients with chronic iron deficiency anemia have small or microcytic cells. And you'll see this actually on your labs. Your labs will actually show this, that they're microcytic in nature. This can lead to mild signs and symptoms of weakness and pallor. Other signs and symptoms include fatigue, reduced exercise tolerance, and fissures at the corners of the mouth. The serum ferritin levels are less than 10 nanograms per ml as well. Treatment of IDA, we want to increase the oral intake of iron from foods like red meat, organ meat, egg yolks, etc. If iron losses are mild, these patients can receive iron supplements, and they can take it with meals in order to decrease any GI distress. So take iron with meals. If it is severe, these patients will require iron solution like iron dextrin, and this is given parenterally, etc. Vitamin B12 deficiency is another vitamin B12 anemia. Excuse me, vitamin B12 deficiency anemia is another type of anemia. A diet deficiency and failure to absorb absorb vitamin B12 from the intestinal tract as a result of a partial gastrectomy, for example, also pernicious anemia, etc., is why these patients may have a B12 deficiency. A condition that results in failure to activate enzymes that move folic acid into precursor red blood cells, cell divisions and growth into functional red blood cells can occur. So when we talk about a precursor, this is before the red blood cells become an actual red blood cell. So when you have this enzyme that does not allow folic acid to go into the red blood cell, then division, because these cells have to proliferate, they have to, there's cell growth and division is impaired. It cannot happen. All right. So again, when this happens, these precursor cells, they undergo improper DNA synthesis and increase in size. So they get bigger. They would get bigger. And so, as we know, when the DNA of a cell is altered or impaired, then the DNA cannot send out proper messages so that the red blood cells and everything that it does as far as its functions just cannot be carried out, because DNA provides those instructions, if you will, kind of like the captain of a ship, providing all the instructions necessary to accomplish whatever they're trying to do. Causes of B12 deficiency. There's a deficiency vegan diets. Some people are vegans and they don't have B12 in their diet, or diets lacking in dairy products. Small bowel resection and also tapeworms can also result in B12 deficiency, etc. There's some additional information there as well. And anemia resulting from failure to absorb vitamin B12, which is called pernicious anemia. This is due to deficiency of the intrinsic factor that is found in the stomach. You all should have known about that in anatomy and physiology. Now, intrinsic factor is a substance that is normally secreted by the gastric mucosa. It is this intrinsic factor that is needed for intestinal absorption of B12. When that intrinsic factor is altered, such as, let's say, if a patient has gastric ulcers, well, it can't produce, if the ulcer is significant enough, it won't be able to produce the intrinsic factor that enables our intestines to absorb the vitamin B12. This does develop slowly. It can be mild to severe. As far as signs and symptoms are concerned, these patients are pallor, or they experience pallor of the skin, the jaundice. They also have what we call glossitis, or AKA they have a smooth, beefy red tongue. Remember that, a beefy red tongue. There's also fatigue, weight loss. They may also have paresthesia, which is an abnormal sensation of the feet, hands, and they also may have poor balance. As far as treatment for vitamin B12, we want to teach them to increase foods rich in vitamin B12, like proteins, fish, eggs, nuts, etc. Supplements if the condition is severe enough. Also, if patients have pernicious anemia, B12 injections are given weekly at first, and then monthly for the rest of the patient's lives. Folic acid deficiency anemia is another type of anemia. This is also diet deficiency. malabsorption syndrome and drugs such as birth control pills and anticonvulsants can also cause this condition. The patients have signs and symptoms that are similar to vitamin B12, except with nerve dysfunction like paresthesia. They don't have that. It does develop slowly. Foods rich in folic acid, green leafy vegetables, liver, yeast, citrus fruit, dried beans, nuts, and nuts rather. Lacking such a diet is a common cause of this particular anemia. Malabsorption conditions such as Crohn's disease are the second greatest cause. Treatment for this anemia is identify adults at risk and minimize it. Older adult patients are at risk. Debilitated patients with alcoholism, patients at risk for malnutrition, and those with increased folic acid requirements. We want to provide a diet rich in folic acid and vitamin B12 to prevent this condition. The last one we'll discuss is aplastic anemia, a deficiency of circulating red blood cells due to impaired cellular regulation of bone marrow. This will lead to, or it fails to produce these cells. They're caused by injury to immature precursor cells for the red blood cells. As far as cellular regulation, what this refers to is all functions carried out within the cell to maintain homeostasis, just as a definition for you. And this includes their responses to extracellular signals, i.e. or e.g. Hormones, neurotransmitters, and so forth. The way each cell produces an intracellular response. Also included within these functions is cellular replication and growth. So when you think about cellular regulation, think about these are the functions that can be altered in some of these conditions. Now, if these patients are exposed to myelotoxic agents like radiation, benzene, etc., and also viral infections, which have been unproven, such as hepatitis B, CMV, can also cause aplastic anemia. Aplastic anemia can occur alone. That AA is not African American, is aplastic anemia in this case. It usually occurs from a patient who might have leukopenia or thrombocytopenia, or pantoopenia, which is a condition that occurs when a person has low counts for all three types of blood cells, red blood cells, white blood cells, as well as platelets. The most common cause, toxic agents, drugs, radiation, or infection. Again, these issues occur due to impaired cellular regulation, which I provided a definition for. Lab CBC shows severe macrocytic anemia, leukopenia, and thrombocytopenia. And also infection is common as well. A bone biopsy, a bone marrow biopsy does show replacement of cell-forming marrow with fat. Remember, within the bone marrow, it is filled with active hematopoietic red bone marrow, but with this condition, it's replaced with this cell-forming marrow of fat. And so, of course, when that happens, you can't produce red blood cells, white blood cells, and platelets in the bone marrow. As a patient actually gets older, that hematopoietic red bone marrow is replaced with fat anyway. And of course, this is why you might see in your older population, you may see they may be anemic, their platelets are low, they may not have enough white blood cells or low white blood cells, which means they're prone to infections and what have you. So this is kind of something that happens with older adults anyway, but with aplastic anemia, it can certainly occur as well. Treatments for aplastic anemia, we want to manage is based on the cause. For example, for transient or drug-induced aplastic anemia, we want to, of course, remove those drugs. Blood transfusions, we want to provide these patients rather with blood transfusions and also DC the offending agent. Blood transfusions are given when the anemia is causing debility and or bleeding is life-threatening. And of course, this is there may be bleeding due to low platelets. Remember, in the bone marrow, it produces platelets. Once the marrow is replaced with fat, you can no longer produce enough platelets, and of course, these patients are prone to bleeding. Now, I want you to be cautious here, because too many blood transfusions can result in an immune reaction to the platelets and shorten the lifespan of transfused cells. So be careful with blood transfusions with aplastic anemia. Other treatments may involve immunosuppressive therapy, splenectomy, or stem cell transplant. I think that's it for that particular area. Let me see. All right. So this next slide is on leukemia. I have already did a voiceover on leukemia. For this particular, I know it might be long, but this is this particular discussion on sickle cell disease and also anemia you have at this point. And so let me know what you think. If you have any questions, just go ahead and shoot me an email. Thank you much.